Hello everyone, this is Raj Padwal. I'm a general internist and professor of medicine at the University of Alberta, and it's my pleasure to welcome you to the 2016 CHEP guideline voiceover. So specifically, we will cover what's new for 2016 in the CHEP guidelines and also what's still really important. Before we begin, I have a disclosure slide to present to you. I won't read the slide out, but you can see here I have a number of disclosures in terms of funding and other activities, and some of this relates to collaborations with the pharmaceutical industry. Just a word on mitigating bias. So I am the past chair of the Canadian Hypertension Recommendations Task Force, and Dr. Rabi is now the new chair. We only discuss classes at the level of the recommendations. We don't go into specific agents. I certainly won't be speaking about off-label use, as all of our recommendations are strictly focused on the evidence. I'm going to give a couple slides by way of background on Hypertension Canada. I know that many of you already know this background, but for the few listeners perhaps who are new, we are the organization in Canada whose mission is to advance health through the prevention and control of high blood pressure and its complications. And our vision, as you see here, is that Canadians will have the healthiest blood pressure in the world. And to a large extent, we have been quite successful at achieving that vision, primarily thanks to all of you out there on the front lines who are treating patients with or at risk for high blood pressure. And because of that, Canada has the highest rate of blood pressure control in the world. I will mention also that for those of you who are not familiar with CHEP, we have updated annually for about a decade or longer, and we will continue to produce annual updates going forward. And this is my opportunity to thank the task force who are pictured here. It's a group of over 70 volunteers and staff who work very hard to achieve the goals of Hypertension Canada and produce the recommendations. And in many ways, a lot of credit should go to these individuals. They subsidize the process, they volunteer. Certainly their expenses and time are not covered, but they do because they are passionate about the field. So a big thank you to all of them. In terms of how CHEP works, it's pictured in this slide. The bare bones summary is that we are split into subgroups, and each subgroup has primarily content experts and clinical experts, and we are very multidisciplinary in nature, so lots of different disciplines are involved in participating in the task force. The subgroups do a literature search every year, and this is done through Angela Eady, who is our librarian, a Cochrane-trained librarian who works at McMaster University. And Angela gives these search results to the topic subgroups, who then go through it, pull any pertinent articles, commiserate over the new evidence produced that year, decide if a new recommendation should be advanced. That draft recommendation then goes through to the Central Review Committee. In terms of mitigation of bias, I should mention that the CRC is free of any industry conflict and composed of methodologists as well as clinical experts and content experts, but primarily very important that they have methodological training. They vet the new recommendation or recommendations produced by a subgroup, discuss with the subgroup about whether it should go forward, and grade the recommendation according to our grading algorithm. And then finally, the recommendation is presented at a one-day consensus conference, which all members are expected to attend. There is a hand vote, and that's followed by an electronic vote. And if a recommendation achieves over 70% consensus, it is added to our list of recommendations in the following year. Following that, process, the work is not done, then we have extensive efforts dedicated towards implementation, knowledge translation, and discussing future potential recommendations or areas of concern or gaps in the recommendations with end users, which we then feed back to the subgroups for the following years. So now to the CHEP 2016 new recommendations. So the big new recommendation relates to intensive blood pressure lowering in high-risk individuals, and this primarily comes from the SPRINT study, although there is also a great deal of broader literature, including 2 meta-analyses published in The Lancet, one by ZXIE and the other by Etihad, ETTEHAD. I won't be discussing, for the sake of time, the meta-analyses and the broader literature, but we will review the SPRINT trial, as the recommendation comes primarily from this study in terms of its structure and content. In addition, other things that are new this year, we would like to emphasize that automated office blood pressure measurement is the preferred method of measurement in the office. This is a new recommendation. Secondly, we have additional new or updated recommendations in potassium supplementation, primary hyperaldosteronism, coronary artery disease, and we also have spent an extensive amount of time producing new recommendations on the diagnosis of hypertension in pediatric patients. Although the slide mentions management, there's not much on management in pediatric patients this year, but it will be coming hopefully next year. I'm not going to discuss the pediatric recommendations today. I'm not a pediatrician. We are going to have a separate voiceover and slide deck for that particular set of recommendations, but a huge congratulations to the pediatric subgroup of CHEP for all of the work and successfully bringing about diagnostic recommendations in pediatrics. What's still important? Well, in today's voiceover, we will emphasize issues that we still think should be emphasized, and perhaps there is some under-awareness of these issues, including the fact that we believe hypertension should be diagnosed exclusively using out-of-office measurements. So I'm discussing here initial diagnosis, and the initial diagnosis should always be ruled in or out using out-of-office measurements, preferably 24-hour ambulatory measurement. In addition, global vascular protection and global cardiovascular risk assessment are very important principles in the management of hypertension patients, as well as attention to adherence, which is a huge issue. We know that many patients over the long term are non-adherent to their antihypertensive drugs, and so working collaboratively with the patient to achieve patient buy-in and maximize adherence is very important. So let's move to the recommendation based on intensive blood pressure lowering. This slide here summarizes the usual office blood pressure threshold values for initiating pharmacological therapy. And I should pause and remind everyone that it goes without saying here that all patients should already be receiving non-pharmacological therapy, including those with hypertension or those at risk for hypertension. That said, you can see here a new recommendation has been added to these other categories that were previously in the recommendations. And that new recommendation says that high-risk individuals, primarily those that fit entry criteria into the SPRINT trial population, for those individuals who have blood pressures above 130 systolic, one can consider initiating pharmacological therapy. And in this slide, we show that if one is to initiate pharmacological therapy, one then aims to achieve a blood pressure of 120 millimeters mercury or less, or it would be acceptable, I think, to say less than equal to 120 as well. The SPRINT trial itself was a trial of over 9,300 individuals. This trial was conducted primarily in the United States and Puerto Rico. It was commissioned by primarily the NHLBI and other governmental organizations in the United States. And the individuals that were enrolled in the SPRINT trial were individuals that were at high risk of cardiovascular events or cardiovascular death. And those included people with known clinical disease or subclinical disease, people with chronic kidney disease, people with an estimated 10-year global Framingham risk of 15% or more, or people that were 75 years of age or older. And so you can see that the population comprising the SPRINT trial was a population of very high-risk individuals overall. I should mention the exclusion criteria of the SPRINT trial because it is important when applying the results in your clinical practice. And I don't think that practitioners should use the inclusion-exclusion criteria to tie themselves strictly. I mean, there is some amount of clinical judgment that has to enter into applying intensive blood pressure lowering to a given patient. But as a general rule, we need to emphasize that some individuals were excluded from the SPRINT trial, and especially those that were at risk of major adverse effects, including frail or institutionalized elderly and individuals who had orthostatic hypotension when standing. In other words, those that when standing had a systolic pressure of less than 110. In addition, other trials are either ongoing or have been done in certain populations, such as those who have type 2 diabetes or diabetes in general, and those who've had a prior stroke. And for this reason, the SPRINT trial excluded study of these individuals. Now, does this mean that automatically intensive blood pressure lowering should not apply to these individuals? Again, I think this is a matter of clinical judgment, and practitioners need to decide for themselves whether they will try to lower BP more in these high-risk individuals. There is some concern from the viewpoint of diabetes that the major trial in the field, ACCORD, was quite underpowered. And in fact, there is good evidence to show that perhaps it was. It was the individuals actually who did the SPRINT trial primarily who did the ACCORD trial. And the ACCORD trial was unfortunately too complicated perhaps to answer the question about intensive lowering and too underpowered. That said, it's not incorrect to not apply intensive lowering to these populations because there is certainly a lack of evidence at this point. And so again, clinical judgment and patient preference should enter into that decision. So SPRINT itself, as I mentioned, over 9,300 individuals, and really the trial was very simple. It was to randomize these individuals to less than 120 millimeters of mercury, that's intensive treatment, versus staying at around 135 to 140 millimeters of mercury. And overall, I think it's very important for me to tell you that SPRINT used protocolized management and long-acting agents, and they didn't give people the choice about whether or not to adjust therapy. If the therapy was not at target, they had to adjust. They had to increase the medication, for example, if in the intensive arm they were above the goal. And so this really speaks to overcoming therapeutic inertia and making sure that treatment is adjusted. And I think that's part of the reason why this slide, when it mentions average number of medications, some may be surprised that only about 3 medications were needed in the intensive arm to get that low, versus only about 2 in the standard arm to get between 135 to 140. And certainly when I think of my practice, that seems like a low number of medications to get to a fairly low blood pressure target. I think this also speaks to the fact that people were screened for adherence, and those that were not adherent were not included in SPRINT. And so it is a subset of hypertensive individuals that perhaps are most adherent. In any event, between the two arms, they roughly achieved their goals. I think the average blood pressure in the standard was 136 versus 122 in the intensive. And it was overall a well-conducted study, stopped early after about 3.3 years of follow-up, but I don't feel that that was too big a problem, as they had over 500 events in this study, so a good number of events to make conclusions. As many of you already know, the outcome was that there was a clinically important and statistically significant reduction in major cardiovascular events or death in the intensively treated group, indicating that this is an important treatment to offer patients, and the number needed to treat was around 60, which compares favorably with many other treatments. And so overall, good evidence for intensive blood pressure lowering. I should mention that in terms of the components of this composite endpoint that were statistically significant, it was cardiovascular death as well as heart failure that primarily drove the benefit seen. So stemming from SPRINT, here is the recommendation. It is for high-risk patients aged 50 years or older with systolic levels 130 or greater, and this all follows what was done in the SPRINT trial. Intensive management to target a systolic blood pressure less than equal to 120 should be considered. And we put less than equal to 120 because the achieved blood pressure was 122, and so we recognize that it should be somewhere around there, keeping in mind that the ultimate goal in SPRINT was to get under 120. Intensive management should be guided by automated office BP measurements. More on that in a minute. And then patient selection for intensive management is obviously going to be important. I think that intensive management is only going to be offered to a subset of all of the eligible patients out there. And really, the patient has to understand and have buy-in for intensive management and agree to close follow-up. Now, I alluded to this issue of automated blood pressure recording. So in SPRINT, automated office blood pressure measurements were conducted, and I think this is very important because if one does not use automated office, the blood pressure may be spuriously high, and so if someone is aiming for 120 or less based on, say, auscultatory readings that are spuriously elevated, in fact they may actually be achieving less than, for example, 110, and the patient may be getting side effects. So a very important issue to remember. So I just want to back up and talk about what are the different office measurements that can be done. So number one, one can do what's called attended office, which means the practitioner is in the room. And attended office can be either auscultation or oscillometric, in other words, electronic. And for it to be attended office but electronic, that means you buy an electronic monitor, perhaps a home monitor, or even an office monitor, but you sit in the room and push the button. And really, I think that's an okay way to do things. We certainly recommend to do electronic over auscultation because auscultation has all sorts of problems and biases that occur. But I think overall, to be attended is suboptimal. Because the white coat effect is present in so many individuals, and because the temptation is there to talk to individuals and to do other things while you're trying to take the measurement, you really want to do automated office measurement, and that's why now it is the preferred way according to the CHEP recommendations. So automated office measurement really means measurement using an electronic or oscillometric device that is placed properly in the upper arm. Of course, the patient needs to be in the proper position for measurement. And the provider takes a measurement with some devices or just starts the machine. But in any event, after 0 to 1 measurements, depending on the type of machine used, the provider leaves the room. And then the automated device takes multiple readings in a serial fashion, usually 30 to 60 seconds apart, and it automatically calculates the mean of those readings. And that is really what we would like practitioners to be doing in the office setting for blood pressure measured in the office. And I should also mention here that the normal threshold between normal and abnormal for automated office is 135/85. And that's been in the guidelines for several years. Pictured on this slide are 3 different types of automated office devices. These three devices here, I believe, are the only ones on the market in Canada, and they are all validated, and any of them are appropriate. From left to right is the MicroLife device. There's the Omron in the center, and that Omron HEM 907 was the one used in SPRINT. And then on the far right is the BP True, and the BP True is probably the most common one used in Canada. It's the one that does 6 readings, throws the first one out, averages the next 5, whereas the other 2 devices mentioned do 3 readings in sequence and average all of them. Now, what is the evidence for automated office? Well, very briefly, I will go over this in about 3 slides. Number 1, I should mention that automated office performs very similarly if it's done in different settings. So it can be done in a quiet area of the waiting room. It can be done overall in a quiet room in the clinic. Although if you do it in the waiting room, for example, a small clinic, you don't need to dedicate an extra room. You can cordon off part of the waiting room and make sure it's a quiet area, and that would be acceptable to do automated office in that area. It can also be done in pharmacies, and in each of these different settings that I've mentioned, the results are pretty comparable. Now, one of the important points about automated office is that it reads fairly similarly, fairly comparably to awake ambulatory, and awake ambulatory is considered the gold standard here for awake readings anyway. And so that's why we recommend automated office over, for example, routine auscultatory, routine manual office, because it eliminates these issues of talking to the patient, white coat effect, and other issues that arise when auscultation is done in the real world, the real clinic setting. I should mention that auscultation in the research world with 2 observers and a double-headed stethoscope is still considered a gold standard, but that very, very careful auscultation is a far cry from the auscultation that is performed routinely in clinics all across Canada and throughout the world, and that's why we don't want clinic auscultation measurements to be used. The second piece of evidence is that automated office BPE correlates better with end organ damage, shown on this slide, left ventricular mass index, microalbuminuria, carotid intimal media thickness, and it correlates fairly well when compared to 24-hour ambulatory measurement. The third piece of evidence is new, and it comes from a Canadian study from Dr. Kazarowski and Dr. Myers and their other colleagues who performed the CHEP trial. And long-term follow-up from the CHEP trial has now been conducted. So this study was, as mentioned, Canadian, over 3,500 Canadians who had a cluster randomized type of design, primarily older individuals, and they had their blood pressures taken in community pharmacies. But the critical point here is that it was done using automated office measurements. And then they had almost 5 years of follow-up for what we would term hard outcomes, fatal and non-fatal CV events. And so the study showed that there was a continuous and a graded increase in the hazard ratio of these cardiovascular events as one looked at increased systolic blood pressure on the left and increased diastolic blood pressure on the right. And you can actually draw a line, as shown here, where the increase became statistically significant, and it was roughly around the 135 threshold for systolic and somewhere around the 80 to 89 threshold for diastolic. And so for this reason, we have kept the 135 over 85 threshold intact. We also don't want people to have to remember many different numbers, as it is 135 over 85 is the cutoff threshold for normal versus abnormal for daytime ambulatory. It's also the threshold to indicate abnormal for a home BP series. And so to keep them all consistent, we've stayed with 135 over 85 as our threshold for normal for automated office blood pressure measurement. And now I would like to turn it over to Dr. Rabi, who is an Associate Professor of Medicine at the University of Calgary. I am the past chair of the Canadian Hypertension Recommendations Task Force, and Doreen is now the new chair, who will continue on with the remainder of the What's New slide deck.
So hello everyone. I will now proceed to talk about our new recommendations with respect to health behaviors. And specifically, adopting healthy behaviors is integral to the management of hypertension, and this year we will be focusing specifically on potassium supplementation. In the 2016 recommendations, everyone will see that we continue to recommend a number of health behaviors that are advantageous in terms of reducing one's blood pressure. And this year we're adding a new recommendation that focuses on potassium supplementation. Specifically, the new 2016 recommendation is in patients not at risk of hyperkalemia, an increase in dietary potassium is recommended to reduce blood pressure. This new recommendation is based on a broad literature that has examined the association between dietary or supplemental potassium and blood pressure. And what we have listed here on this slide are a number of systematic reviews that have examined and summarized randomized controlled trials that look at potassium interventions on the reduction of blood pressure. And specifically, we will focus in on a systematic review done by Alberto in 2013, as this was one of the largest systematic reviews and was done very, very well and gave us rather compelling evidence of the potential benefit of increased dietary potassium on blood pressure. This forest plot comes from the Alberto systematic review, and what you'll see here is a number of randomized controlled trials, and what's listed in the forest plot is the degree of systolic blood pressure reduction that was achieved with increased potassium supplementation. And this forest plot is stratified by the patient's baseline blood pressure. So at the top of this forest plot, we have patients that were normotensive but were exposed to higher potassium diets or supplements. And in the lower part of the plot, we have patients that were hypertensive and then exposed to a potassium supplementation or a dietary increase in potassium intervention. And what we have here is that the pooled estimate of effect shows that amongst patients who were hypertensive, patients who received increased potassium in their diet or via supplementation had a mean blood pressure reduction of 5.32 millimeters of mercury. And this was found to be statistically significant, indicating that indeed potassium supplementation does have a favorable effect on blood pressure. At the top of this plot, we see that the mean blood pressure reduction associated with potassium supplementation in normotensive patients, however, was only 0.09 millimeters of mercury, suggesting that potassium supplementation is most effective in hypertensive patients, but there's probably limited or no role in potassium increases in patients who are already normotensive. One of our central recommendations in our health behaviors chapter is the recommendation on a lower sodium diet. And this new recommendation for potassium supplementation enhances that existing recommendation. And what this plot shows, and this is data from the DASH trial, is that there are additive benefits of potassium supplementation to sodium reduction. So that even in a sodium restricted diet, we still see a beneficial effect of potassium supplementation on blood pressure. So to summarize this evidence, we found that there was a quite compelling evidence that potassium supplementation leads to decreases in blood pressure, specifically amongst hypertensive patients. And this effect of potassium is modified by the sodium intake, such that we will see the greatest reductions of blood pressure when sodium intake is high. Even at low levels of sodium intake, we still see some added benefit of potassium supplementation. Increasing dietary potassium or adding potassium supplementation to a patient's medical regime needs to be done cautiously, and it's imperative that we identify those at high risk for hyperkalemia prior to making any decisions about increasing dietary or supplemental potassium. And therefore, along with our recommendation for potassium increase, we also have this cautionary note that prior to advising increases in potassium intake, the following kinds of patients who are at high risk for hyperkalemia should be assessed for suitability and then monitored closely after increasing dietary potassium. And these are patients taking renin-angiotensin and oral aldosterone inhibitors, patients on other drugs that can cause hyperkalemia, such as trimethoprim and sulfamexol, amiloride, or triamterene, patients with chronic kidney disease, and patients with a baseline serum potassium of greater than 4.5 millimoles per liter. Our next new recommendation examines our current approaches to screening for patients with primary aldosteronism. And specifically, we're updating the evaluation of patients with suspected secondary forms of hypertension with a focus on primary hyperaldosteronism. So in 2016, we've added this recommendation in the Endocrine Hypertension chapter. In patients with primary hyperaldosteronism and a definite adrenal mass who are eligible for surgery, adrenal venous sampling, or AVS, is recommended to assess for lateralization of aldosterone secretion. AVS should be performed exclusively by experienced teams working in specialized centers. This recommendation for adrenal vein sampling has arisen from a number of studies that suggest that the addition of this lateralization investigation is extremely helpful in identifying appropriate surgical candidates for adrenalectomy. This study by Young demonstrated that if patients were imaged alone, they would incorrectly exclude 21% of patients for surgery who would actually benefit from surgery. And based on CT alone, 25% would have received unnecessary surgery because in these patients, they actually had bilateral secretion of aldosterone and therefore underwent unnecessary adrenalectomy. Our next recommendation addresses the issue of hypertension in patients with known coronary artery disease. We've introduced a recommendation that updates our current approach to the treatment of patients with hypertension and concurrent coronary artery disease. Until 2016, we had a recommendation that for patients with stable angina, beta blockers were preferred as initial therapy, but calcium channel blockers could also be used. In 2016, we've introduced a new recommendation that makes beta blockers or calcium channel blockers equally strong therapeutic choices in patients with known coronary artery disease. So our new recommendation is that for patients with hypertension and stable angina pectoris, but without prior heart failure, myocardial infarction, or coronary artery bypass surgery, either a beta blocker or a calcium channel blocker can be used as initial therapy. This new recommendation that gives calcium channel blockers and beta blockers equal status in terms of first-line therapy for patients with coronary artery disease is based on a number of studies that have suggested that calcium channel blockers and beta blockers are probably equally effective at reducing coronary events in patients with established coronary artery disease. We will be reviewing 3 studies right now that support this recommendation. And the first is the Tibet trial, which was a relatively small trial that examined the use of atenolol versus nifedipine in patients who had had a prior coronary event. They were then followed prospectively for the development of a second event, and this could be an MI, cardiovascular death, heart failure, or acute coronary syndrome. This trial, which enrolled just over 500 patients, demonstrated that atenolol and nifedipine were equally effective at reducing coronary events. The next trial that examined a very similar question was the APSIS trial, and like the Tibet trial, this trial also enrolled patients with coronary artery disease. They likewise randomized patients to metoprolol or verapamil and followed them prospectively for the development of major adverse cardiovascular events. Similar to the Tibet trial, the APSIS trial also demonstrated that the event rates were very similar amongst patients who received metoprolol or verapamil, again suggesting that these agents are fairly comparably effective at reducing events in patients with established coronary disease. However, the trial that's probably most provides most compelling evidence for this revised recommendation is the INVEST trial. And this was a much larger trial enrolling just over 22,000 patients that not only had coronary disease but also had hypertension. And patients were randomized to receive either a calcium channel blocker based strategy in which their primary agent was verapamil versus a non-calcium channel blocker based strategy which include atenolol. And other agents could be added on in time to achieve blood pressure targets. These patients were then followed prospectively, and again, the primary outcome of this trial was major adverse cardiovascular events. They found that through the course of follow-up, that the event rates were very similar amongst patients who received a calcium channel blocker based strategy versus those who received the atenolol based strategy. Again, suggesting that these two agents are likely fairly equally beneficial to patients with hypertension and coronary artery disease. So that concludes the presentation of our new recommendations that will be present in the CHEP 2016 guidelines. But we want to take this opportunity to underline some things that still remain very important and remain in our 2016 guidelines recommendations manuscript. And one of the first things that's of critical importance is that the diagnosis of hypertension should be based on out-of-office measures. Illustrated on this slide is our new hypertension diagnostic algorithm, and this algorithm contains similar content to that which was published in 2015. However, we hope that the presentation of this algorithm is clearer and more user-friendly. And again, this algorithm is one that emphasizes the primacy of out-of-office measures in the diagnosis of hypertension. And again, we want to emphasize the use of out-of-office blood pressure measurements because ambulatory blood pressure monitoring, or ABPM, has better predictive ability than office blood pressure measurement and is the recommended measurement modality for out-of-office measurements. Home blood pressure measurement, or HBPM, has better predictive ability than office blood pressure measurement and is recommended if ambulatory blood pressure measurement is either not tolerated, not readily available, or if the patient prefers to use home blood pressure monitoring. And the use of out-of-office blood pressure measurements have the advantage over traditional office-based measurements as they more effectively identify patients with white coat hypertension and masked hypertension. And this slide illustrates again the performance of various blood pressure monitoring methods and their ability to predict clinically important outcomes. And specifically, these data displays show the association between systolic blood pressure, diastolic blood pressure, and the outcome of left ventricular hypertrophy on the left, and the association of systolic blood pressure and diastolic blood pressure with albumin excretion ratio on the right. And as you will see, the correlation between the out-of-office measures, specifically home blood pressure monitoring and ambulatory blood pressure monitoring, are more strongly associated with the outcomes of LVH and albumin excretion ratio. Again, outlining the strong predictive ability of these out-of-office measures relative to office-based measures. Another element of the CHEP 2016 guidelines that again deserves some emphasis is the management of hypertension is all about global cardiovascular risk management and vascular protection. And I think this is raised by our addition of our new SPRINT-related recommendation. But again, I think it emphasizes the importance of global cardiovascular risk assessment and management in patients that are at high risk for adverse cardiovascular events, like patients with hypertension. And it's important to remember that 8 out of 10 hypertensive patients have at least one additional risk factor. So comprehensive risk factor assessment will identify these other cardiovascular risk factors and lead to appropriate treatment and long-term cardiovascular risk reduction. Beyond identifying perhaps occult cardiovascular risk factors in patients with hypertension, comprehensive cardiovascular risk assessment has been shown to be an important component in patient care. Evaluating a patient's cardiovascular risk and discussing this risk with the patient is associated with significant blood pressure reduction and improved care outcomes. It's of critical importance to identify patients that are at high risk for adverse cardiovascular events because there are co-interventions that can be extremely helpful in reducing their long-term risk of heart disease. We have an existing recommendation for statins in patients that are at high risk for heart disease by being hypertensive and having established atherosclerotic disease, or at least 3 of the following factors. Male sex, being 55 years of age or older, being an active smoker, having type 2 diabetes, having a total cholesterol or HDL cholesterol ratio of 6 or higher, having a history of premature heart disease in the family, having a prior stroke or TIA, having left ventricular hypertrophy, having EKG abnormalities, having albuminuria or chronic kidney disease or peripheral vascular disease. Again, if a patient has established atherosclerotic disease and is hypertensive or has at least 3 of those listed risk factors, the use of a statin is recommended. Another adjuvant therapy that should be considered in these high-risk patients is aspirin. And currently, we do recommend that low-dose aspirin be used in hypertensive patients that are over the age of 50. And again, we do recommend that caution be used with aspirin therapy if the blood pressure is not well controlled. Another strategy to help protect the vasculature includes smoking cessation. And in 2015, we introduced 2 guidelines that give explicit direction on how to encourage smoking cessation amongst our patients. And this includes a recommendation that tobacco use status for all patients should be updated on a regular basis, and healthcare providers should clearly advise patients to quit smoking. We also suggest that advice in combination with pharmacotherapy, including varenicline, bupropion, and nicotine replacement therapy, should be offered to all smokers with the goal of smoking cessation. The last point we'd like to stress is that the most important step in prescribing of antihypertensive therapy is achieving patient buy-in and adherence. The patient needs to be an active and willing participant in the care of their blood pressure, and ensuring that patients understand their therapy and are adherent to the therapy is critical to achieving our blood pressure targets. There are several strategies that can be used to improve adherence in patients that are being treated for hypertension, and these include educating the patients and their families about their disease and their treatment regimens, and this can be done verbally by reviewing these things in clinic or giving them written educational materials that they can review outside of the clinic. There's also great benefit to using an interdisciplinary care approach and coordinating care, such as the work site or in the community in places like pharmacies. Healthcare practitioner-based telephone contact, particularly over the first 3 months of therapy, is critically important to ensure, again, that the patients are not having any adverse effects related to their therapy, and they can work with their care provider to troubleshoot regarding any concerns they might have regarding their antihypertensive therapy. It's really important to empower and encourage patients to take greater responsibility and autonomy in their care, and this can also be achieved through regular monitoring of their blood pressure at home. Other approaches that can increase therapeutic adherence, including assessing adherence to both medication and behavior interventions at every office visit. We also should be teaching our patients to take their pills on a regular schedule associated with daily routine activities, such as brushing their teeth or eating meals. Simplifying medication regimens as much as possible can be very helpful in promoting long-term adherence. Special consideration should be given to long-acting once-daily therapies whenever possible. Along those lines, simplifying therapies by using single pill combinations can also be very effective at encouraging long-term adherence. And utilizing unit of use packaging, for instance, blister packaging, in patients that have more complicated medical regimens can greatly improve patient adherence to therapy. So that concludes our voiceover presentation for our 2016 guidelines. Listed here are a summary of our new recommendations, and here again we have listed what we still want to emphasize as important within our recommendations. We appreciate you taking the time to listen to this recording of what's new for the 2016 Hypertension Canada guidelines. And we encourage you to visit the Hypertension Canada website for more information, for access to other educational and presentation materials. Thank you again.